Geocyst is one of the features of the degenerative disorder osteoarthritis. It is normally it is not commonly it is not so large, but if it is large and the more widely established, you have to raise a concern about CBBD or pseudo gout. Okay, mainly related to degenerative osteoarthritis associated with other feature narrowing osteophytes, and if there is it could present with large subarticular lucencies with sclerotic rims in the medial and the lateral femoral condyles. Okay, here is examples for geocyst in the MRI. So it is not tumor, it is not chondroblastoma, it is degenerative, so it is old age. So don't say that it is chondroblastoma. It is not. It has not. It is cyst. So it is not chondroid matrix. It is will not present with internal calcification. Could present with sclerotic rim, but the matrix itself will be lucent in the X-ray, and in the MRI will not be heterogeneous like the chondroid lesion. Okay. So consider this bone. It is cyst. So it is fluid in fluid sensitive sequences, and not chondroid matrix like the chondroblastoma, if and or chondroid tumor. Ganglion cyst, it can present in the carpal bones, and actually it is now well known well known lesion in the MSK reporting in the intraosseous ganglion cyst. Okay. It can present also in the femoral head and the distal portion of the radius, the ulna and distal end of the femur. It is in the MRI as like cyst, low signal in T1, high signal in the fluid sensitive sequences, and can have sclerotic borders. Okay. Here's clear cell chondrosarcoma. Can see this epiphyseal lesion. Low signal in T1, heterogeneous signal in fluid sensitive sequences because of the chondroid mineralization, and you can see there is no invasion of surrounding structures. You cannot say this chondroblastoma or clear cell chondrosarcoma unless you know the age of the patient. Okay. Here it is osteochondroma, which merge from the metaphysis toward the away from the joints, not toward the joints. Okay, it can present with sessile or be pedunculated, but the most important is the medullary continuity. Okay. Examples of other example for osteochondroma. Here is the in the spine. Here in the spine is very painful and is can make neural compromise. These examples in the iliac and sacral bone, in the scapula and in the distal femur, and here it is in the ilium. But take care because this could be associated with secondary chondrosarcoma. Okay. Osteochondroma is a metaphyseal lesion, has a narrow based when pedunculated or broad based when sessile, project away from the joint with very important sign. Cortical and the medullary continuation with the mother bone is very important to say osteochondroma. Cartilaginous cap of high T2 signal, which is less than, I think it is 1.5 centimeter. This is the borderline, but for the osteochondroma, it should be less than 1 centimeter. Okay, in the osteochondroma. This is a diagram for the distribution of osteochondroma. The other disease which is similar to osteochondroma is the Trevor disease. It involves the epiphysis. The other name, dysplasia epiphysealis hemimelica. Trevor disease is rounded intra-articular bodies attached to the epiphysis. There is no medullary continuation, usually unilateral and single side of that extremity, medial more than lateral of the limb, lower than more than common than the upper, and the ankle is the most common site. We have three forms: localized, monoarticular, or classic, which represent 2/3 of the cases, or generalized form. Here is the subangual exostosis. These lesions are most commonly found in children and young adolescents. Although usually appear as well circumscribed bone, they lack clear contiguity of both medullary cavity and cortex. It's very important to say in all views that the lesion is continuous with the medulla. Okay, which helps to distinguish them from osteochondroma. So it is subangual ecdystosis. Bizarre parosteal osteochondromatous proliferation, neural lesion is very common. This mineralized lesion, which is attached to the cortex, but without medullary continuation. This is very common in the hands, and there are the enchondroma, which is intramedullary lesion, chondroid matrix, low in T1, heterogeneous in fluent sequences, and the progression of size is very important to assess for any neoplastic transformation. Okay, multiplicity is very important to say the number, and either it is present elsewhere, because if there is multiple enchondroma, what what is your next step? What is the diagnosis which should hit your mind? Can you give me your expectation on the chat, please? Or if there is soft tissue? Very good. Okay. So this enchondroma will define lobular lesion with intermediate signal on T1 and variable increased signal in the protein density and the fluid sensitive sequences. Uh, Large lesions may show a variable degree of endosteal scalloping. It's very important to measure the endosteal scalloping should not exceed the 2/3 of endosteal scalloping on one side. If more than 2/3, this means that there is malignant transformation. Okay. The red flag signs: aggressive or worrisome features, endosteal scalloping more than 2/3 of cortical thickening, marked uptake on bone scan, cortical destruction, soft tissue mass, periosteal reaction. The pain, newly developed pain, is a red flag sign for enchondroma. Large size, more than 5 centimeter in all the lesions, should be closely watched out. You have to take care of any large lesions, even it is benign, even it is lipoma. Any lesions more than 5 centimeter, you have to consider the potentiality for malignant transformation. Here is the chondrosarcoma uh, transformation in chondroma, or and low grade chondrosarcoma. I think it is fair example now. You cannot complain. Okay, and this high grade chondrosarcoma, you can see that you cannot differentiate between this and this. Only the age. Central well-defined area of stable decalcification, central calcification with distinct margins. But here you can definitely say that is malignant tumor, chondroid matrix lucency with calcifications and large destructive soft tissue mass. Okay. And the MRI determine extent of the lesion, and either there is escape lesions or not, extension to the joints, the association of the of soft tissue component, and periosteal reaction. Here is a table to how to differentiate enchondroma from chondrosarcoma. Here is that less than 5 centimeter, could be more than from 5 to more than 4 to 5 centimeter. Both of them could have poorly defined margins. There is periosteal reaction could present in the chondrosarcoma or not. Is very important point that the endosteal scalp, very important point. Okay, this cortical thickening is uncommon in chondroma, and the common chondrosarcoma soft tissue mass is uncommon with enchondroma. Bone scan, no uptake in the bone scan. In the MRI, here intense confluent enhancement and abnormal peritumoral marrow and soft tissue signal. Okay, chondroma exodofibroma, it is extremely rare. It is benign cartilaginous neoplasm that account for less than 1% of all bone tumors. It is metadiaphyseal of the long bone eccentric metaphysis around the knee, 50% proximal tibia, well-defined geographic osteolytic lesion, expansile lesion with cortical thinning. Okay, this is chondromyxoid fibroma. Example for chondromyxoid fibroma, it is large expansile lesion. Okay, is for the other tumors, which is benign osteoid osteoma, less than 2 centimeter, pain waking up the patients in the night, it responds well to salicylic acid, acetyl salicylic acid, as aspirin, surrounded with marrow edema, double donut sign in bone scan. It is the it can happen. It can present long bone or the small bone or even the spine, diaphysis and the metaphysis. It can the osteolysis, the nidus is less than 2 centimeter, which can mineralize with time, perifocal sclerosis, solid periosteal reaction, and bone marrow edema. Okay, and these examples take care because these come in the exam, and the common differential is the stress fractures, stress fracture of the femur. The other differential is the osteoid osteoma. Okay, it is we can move to osteosarcoma. It is mainly metaphyseal, and the other types would be low grade parosteal, intermediate grade vagetoid, and the periosteal. Could be high grade telangiectatic osteosarcoma. Mainly it is metaphyseal and very painful. Okay, this is a conventional osteosarcoma. It's primary central osteosarcoma. It is around the knee mainly. Flat bones can involve flat bone spine. It can be central or intracortical or surface like parosteal or periosteal, which is or high grade osteosarcoma. Role of imaging: it assists the extension of the tumor within the medulla. It assists extraosseous soft tissue extension and the relation to the vessels. Very important to give a comment on the joints and the neurovascular bundle in the exam or in your report. Okay, detection of intramedullary skip lesions. Okay, osteosarcoma, the location, it is commonly metaphyseal, and it is osteoid matrix, more likely to be eccentric, not central. The risk calcifications and the mineralization of the osteoid matrix, and there is exuberant calcifications and the periosteal reaction, some burst, and we can have Koodman's triangle. If we can have Koodman's triangle, and the pattern of invasion of the bone is permeative lytic lesion or moth-eaten appearance. So if we build our opinion based on what we said in the beginning of the lecture, that this high grade or a very aggressive lesions according to the pattern of growth. Okay, and so the pattern of growth is moth-eaten or permeative lesion. It's very important exam to tell the examiners that either wide zone of transition. These ones you say wide zone of transition. It means that this lesion is malignant. Narrow, they give an impression that you are speaking about benign tumor. Okay. Osteosarcoma in the MRI, it adds little to the diagnosis, but it is invaluable for local staging and assessing any extension. It can demonstrate any intramedullary and extraosseous extension, as well extension into the adjacent joints and across an open growth plate. Osteosarcoma is highly vascular tumor with early hematogenous mets to the lung. First presentation for the osteosarcoma could be pneumothorax. And it is not uncommon to have skip mets. So MRI is very important, that there is lesion here, skip mets, that you can find normal normal bone, and then you can find another lesion. So skip myths is very important. The role of MRI in the evaluation of skip myths is very important. And this is one of the common questions to be asked in the FRCR exam. When you ask the examiners that I want to MRI, he will ask you why MRI. You have to tell him, I want to assess neurovascular bundle. I want to assess the extension to the intra-articular extension, and also I want to assess for any other skip lesions. Okay. These examples for the MRI for the osteosarcoma, you can find this schistoid matrix, periosteal reaction, the and the Koodman's triangle. Okay, some burst, some it is not some burst. This is mainly this Koodman's triangle. Okay, osteosarcoma. These other examples: vegetoid osteosarcoma. 50% of bone sarcoma arising after 50 years of age are secondary to Paget disease. And osteosarcoma is more common than a fibrosarcoma or malignant fibrocystoma. Malignant changes is reported up to 14%, which is not low percent of cases of Paget disease, male more than female. Okay, the location is commonly seen within the pelvis or femur, which is the target of the Paget tumor. Paget disease is the target. That it's a target. The first target is the iliac bone. The spine is usually spurred in the X-ray and CT bone destruction with wide transition zone and the large soft tissue mass. This example for Pagetoid osteosarcoma, you can find that this the Paget thickened cortex, narrowing of the medulla, coarse medulla, and here's the soft tissue component, and this the destruction, the bone destruction, denoting that secondary osteosarcoma. Okay, radiation osteosarcoma it happens when it is not uncommon and it is the most common tumor to associate with the meningioma, the most common tumor which happen following radiation therapy. So you have to know the history of the patient, history of radiotherapy, more than 3-year latency, histology different from the original tumor, and usually more than exposure of 30 gray is required uh, uh, to be to cause osteosarcoma. Uh, in the CT, the bone destruction and soft tissue mass, there is soft tissue mass, periosteal reaction, and the radiation change within the underlying bone. There is no specific signal characteristic in the MRI. Here is this the radiation osteosarcoma. Cholangiocytic osteosarcoma is composed of septated blood-filled cavities, highly malignant tumor. It is the main differential between the cholangiocytic is the aneurysmal bone cyst. It present with septated blood-filled activities and involve mainly the femur, tibia, and the humerus. In the X-ray, predominantly lytic lesions. In the CT MRI, subtle matrix mineralization, extensive hemorrhage with fluid levels. It is very important to differentiate between the benign fluid level, and the malignant fluid level. Many authors say that if you look at the tumor in the MRI and the sagittal sequence and find that more than 70% of the tumor are presenting with fluid level, it is more likely to be benign tumor. Okay, this is one of the main differential. The other thing in the telangiectatic osteosarcoma, you will find thick enhancing nodular septations, which is not present in the aneurysmal bone cyst, which is present with smooth, thin, non-enhancing bony septations. Okay, here is periosteal osteosarcoma. It involves diaphysis, most commonly in the tibia. Poor, the prognosis is better than the conventional osteosarcoma, but worse than the parosteal osteosarcoma, which is present in older age. Soft tissue mass, periosteal reaction, cortical erosion, and cortical thickening, rare intramedullary extension. Periosteal reaction often extend perpendicularly from the inner cortex to the outer margin of the tumor. Here is the example for periosteal osteosarcoma. Here is the diagram demonstrating the distribution. Here is in the MRI. The next is parosteal osteosarcoma, most common type of juxtacortical osteosarcoma, age from second to fourth decade, metaphysis of long bones. Most common location is the posterior aspects of the distal femur, and in the FRCR exam, it is very important to differentiate it from the uh, um, myositis ossificans following the hematoma, as the calcification here in the parosteal osteosarcoma is central compared to the peripheral myositis ossificans. And don't ask for any patient with a history of of trauma and have soft tissue mass with calcification. Don't ask for biopsy, because the biopsy will be osteosarcoma, although these patients likely to have myositis ossificans. You cannot differentiate between myositis ossificans and parosteal osteosarcoma by the pathology. Okay, there is no aggressive periosteal action in parosteal osteosarcoma. It is the tumor is attached to cortex by broad pedicle. This is what's called like cleavage sign. Okay, this cortical thickening due to focal expansion of the inner portion of the tumor and diffusion of the cortex. In the parosteal osteosarcoma in the MRI, the ossified tumor is predominantly low on T1 and T2 when there is any unmineralized soft tissue mass larger than 1 centimeter, or the lesion is predominantly high in T2 signal. The tumor is more likely to be high grade. Okay. There is examples for parosteal osteosarcoma in the X-ray, and here is the CT, and here is in the MRI. I will stop here because I should in the next lecture to continue hold the bone tumors according to the curriculum and how to differentiate between them. I don't like to just spend to just to make it too long, because if I exceeded the osteosarcoma, I have to continue to the end of the lecture. So we will continue in the next lecture. I hope you get benefits from today's lecture. I'm sorry for this organization. I had just finished my MDT. Any questions?